The next patient is a 91-year-old gentleman who had diabetes. He suffered from acute cholecystitis in November this year. Emergency cholecystectomy was not performed at that time because of advanced age. Urgent percutaneous cholecystostomy was then performed. Cholecystogram last month showed the presence of gallstone, and there was free flow of contrast into the duodenum. The patient was now with a PTC. This is the cholecystogram. Today we are going to have US plus gallbladder drainage.
Hi, Ken. Good afternoon.
Hi.
I'm Dr. Lee, and co-chair with me, Dr. Francis Mock. Hi.
Good afternoon.
Good afternoon.
Yeah. I just inserted the echoendoscope, and this is a therapeutic curved linear array echoendoscope. And the reason why we've selected the therapeutic with the large channel, it's 3.7 millimeters, is because we may be inserting a stent to internalize his gallbladder drainage. So right now he has an external drain, and the hope is that we can internalize this today. I just inserted the scope down, and I don't know if you have the ultrasound image there.
Yes, we have.
So I've got the tip of my scope in the bulb, and I'm just going to make some small movements. You can see on the left-hand side, this should be the gallbladder. You can see there's some debris inside of it, and there's also the catheter that creates some acoustic shadowing inside of the gallbladder.
Yep.
There we go. So now I'm going to just enlarge the image a little bit. There we go.
A lot of things inside the gallbladder.
It's interesting. There's a lot of material inside of the gallbladder. And then I believe we also heard that he might have some stones in the gallbladder as well. I'm wondering if on the left side you can see some echogenic structures, some creating some shadowing. Let me see where the cursor is here. Cursor, here we go. So I'm thinking the catheter, oh, maybe that's not the cursor. Ah, here it is, the arrow. So the catheter looks like it's down here. I'll just turn off the Doppler, pulse Doppler. Yeah.
Is it unusual that after a month of the external drainage still has so much sludge inside?
Well, it's inspissated, and what I think is it's not draining. So he's probably not getting ideal drainage, clearly, because there's this inspissated, this very thickened sludge material inside of the gallbladder. And I'm sure now, as I look at this, on the left-hand side, you can see there's shadowing. So there, on the left-hand side of the gallbladder wall, you can see echogenicities with shadowing, and I think those are all stones here. So let's now just consider the anatomy. We've got the gallbladder wall here. We can follow it like this. And I want you to now focus on the space between the duodenum, so we're in the duodenal bulb, and the gallbladder, this space right here. You can see there's this echogenic space between the gallbladder wall here and the muscularis propria of the duodenum here. What this is telling us is that the gallbladder is clearly not adherent to the duodenal wall. And of course, normally the gallbladder is not. But sometimes when the gallbladder is chronically inflamed, similar to a pseudocyst, it can become fused with the gastrointestinal wall, with the bowel wall. But here, not only do we see this echogenic layer, but we can also measure a distance. And Anthony's helping me out here with his system.
Would it affect your decision of internal drainage?
Right. Yes, because the point to be made is that there is a high risk of leak when you drain the gallbladder for a case like this. This is not like a pseudocyst where the walls are fused and the risk of leak into the interposed space is low. Here, that risk is high. Therefore, what we want to do is to minimize. Ideally, we want to eliminate any exchanges over a guide wire, because it's during an exchange of a dilating instrument over a guide wire that leakage can occur. And we would also ideally like to eliminate the dilation of our tract to insert our stent. Now, obviously, the only stent you could use in a situation like this would be a covered metal stent. So this is maybe an opportunity to show you a new stent. I'm going to talk about this stent tomorrow morning in my lecture on EUS-guided transluminal therapy. It's called the Axios stent. And what's unique about the delivery system for the stent, so the stent itself is lumen opposing. It's got two flanges that are going to pull both lumens, the duodenal bulb lumen and the gallbladder lumen, in apposition with one another. And that will, of course, minimize any risk of leak. And, of course, the stent is fully covered. But in addition, the delivery system is going to use cautery to enable me to advance the delivery sheath, contains the constrained stent, into the gallbladder, and then immediately deploy the stent. So I'm not going to do any over-the-wire exchanges. In fact, I'm not going to puncture the gallbladder with an FNA needle. I'm just going to go directly into the gallbladder with the stent delivery system.
Okay.
Let's use the 15. Right now, this stent comes in different sizes, and we have a 10 millimeter diameter and we have a 15. And because we just saw that there's a lot of debris in here and some stones, I think what we'll do is we'll use the larger one, the 15, because that will enable us afterwards to go through the stent. We're going to use the stent as a port to do transluminal endoscopy. So we can go into the gallbladder and actually do the equivalent of necrosectomy with our walled-off necroses. We can go into the gallbladder and we can debride and clean out the gallbladder lumen.
Ken, do you want to show the external view of the stent?
Yes. So Tom, why don't you hold it here against right here? So we have a
maybe we show it on the box first, because the box has a picture of that stent.
Okay.
Otherwise, the audience will not understand what it is.
All right, so now the box here, so it's called hot Axios, and the reason why it's called hot is because it uses cautery to advance the sheath, the stent delivery sheath, into the target cavity, in this case the gallbladder. And the stent is shown here, so in this profile view you can see the two flanges, and these flanges are lumen opposing. The length of the stent is 1 centimeter. The diameter here, the diameter of the tubular portion, or what we call the saddle here, this is going to be 15 millimeters in this case. It also comes in a 10. Now the flanges here, of course, are wider, and they are, I think, 27 millimeters in total diameter. Now in the gallbladder, it's not an issue because it's very capacious. If you're in the bile duct, then of course you're going to need to select a stent size or a flange size that will fit in the lumen. In the bile duct, of course, you have a more constrained lumen. And this is just another image of that stent.
So in the center is a covered stent.
Yes, in the center this is fully covered with silicone.
Okay.
And the flanges are covered as well. So the entire stent is covered. And that covering is, of course, important to prevent leakage. But of course you have the lumen apposition holding the walls together, and that also prevents leakage between the two cavities. And now we can just move quickly to show the tip of this. So this is the hot tip, and the tip is ceramic, and it is conical or bullet shaped, so it tapers towards the tip. So it's acting actually like a dilating bougie. But along the tip here is a fine diathermic wire. And that wire delivers cautery, and that wire is extremely fine and actually wraps around the very tip of the catheter in a ring-like fashion. So you're going to get cautery at the very tip and along the side of the tapered bougie tip. The concept of cautery here is different from the cystotome. So you're familiar with, for example, Cook has a cystotome. There's an Endoflex cystotome. Those are solid ring, diathermic rings. This is not a diathermic ring. Here you're using cautery just to enable easy and smooth entry into the target cavity. Now, I'm going to show you this on the scope, but there are two components to this. This is all designed similar to an FNA needle. It's lure locked onto the scope, and you advance the sheath using this first hub here by advancing that, and then you deliver each of the flanges, maybe bring that down a little bit, each of the flanges on the second hub here. Here's the second hub. Let me just show you that after it's lure locked to the scope, though. Now, one of the things I want to do before we get started is I want to just check my position inside of the bulb, because we want to make sure that we have enough room inside of the bulb to deliver the flange. Can I have an endoscopic view maybe a little bit larger?
While you are preparing, we need to switch to room 5 for the final steps.
Sounds good.
Room 5, please. You
Now,
are back.
to do our entry, our hot entry into the gallbladder, I have inserted the handle no different than the way we would insert an FNA needle. It is lure locked to the port. And as mentioned before, there are two components here. There's hub number 1 and hub number 2. Hub number 1 advances the sheath forward, so that's the sheath that contains the constrained stent. And then there's hub number 2, and by pulling this hub upwards, we will first deliver the distal flange, and that will lock at this point, and then we're going to deliver the proximal flange, and the release of each of those flanges is completely independent of one another, and that's really key, that you can control, the endosonographer can control the release of the flanges, him or herself. There are locks here. These are safety locks, so I'm going to start by now unlocking hub number 1. Now, you should have your EUS view now. I'm going to have my assistant just hold the scope like that. And you can see up here, this is the tip of the diathermic tip of the catheter. And I'm just going to tent it a little bit forward like this. It's a good position. And then I'm going to press on the pedal, and then I'm going to enter into the gallbladder.
Do you want to show them the X-ray view as well?
Let's take a quick look at the X-ray so you can see. Now, normally we actually don't use X-ray for this because there's no need unless you want to try to fill the bile duct through the gallbladder, through the cystic duct. But step on the X-ray and we can show you here the position, and we're in the bulb right now so you can see the gallbladder. And because there's a percutaneous drain, we have the luxury of filling it with some contrast to show you the gallbladder. Of course, normally you wouldn't have that. All right, now, did we preload with the, yeah, there's really no need. I mean, one can preload this with a guide wire. There isn't a need for that. But if we do a bile duct case maybe tomorrow, then in that case we like to preload with a guide wire and advance the guide wire after we're inside of the target. All right, so I'm going to have you hold this again, and we're ready to go. Okay, so I'm using a pure cutting current here to go in, and it's 100 watts, effect 5, and we're ready to go. And I'm in. All right, now as soon as I'm in, I am going to lock. I'm going to lock the sheath. There it's locked. The next step, I'm going to unlock, and let me see if I can just show you the catheter a little bit better. I'll just torque a little bit. Do you see that? Do you see the lengthwise echogenicity of the catheter? Just hold that a little bit counter.
Yes, very well.
Very nice. Now I've unlocked hub number 2. I'm now going to deploy the distal flange, and as soon as that deploys, it will lock in place. Do you see now the distal flange? It's very echogenic, sort of oval. I'll try to torque a little bit so you can see it better.
Yes.
There it is. So the cursor up here, there it is, right here. So now the distal flange is deployed. Everything is very safe, and what we're going to do is we're going to switch to an endoscopic view. Now, at a more advanced stage, you can do the whole procedure under EUS guidance. You don't need to switch to the endoscopic view. But in this case, we'll demonstrate it with the endoscopic view. And so we're going to switch. Now I'm going to put some air into the lumen, and I'm going to pull back slowly and torque and look for the catheter. All right, so I'm pulling back slowly, looking for the catheter. And you can see we're sort of pulling a little bit there, looking for the catheter. Now the catheter's coming into view. Do you see on the right-hand side there's white?
There's a whitish catheter.
Yes.
Yeah.
All right.
And then you can see the black mark.
There's the black mark, and I'm going to pull back a little bit more now to get a little bit more of the black mark. Also pull back a little bit on the scope. There's the black mark in good position. Once you see the black mark, you can now deploy the proximal flange. And I'm just going to pull back a little bit on the scope. Pull back just a little bit. Just hold it like that. And now the proximal flange will deploy. There's the proximal flange coming out. Let me just torque a little bit more so you can see it better. Now the proximal flange has been deployed, but I need to just advance it out of the working channel a little bit. And this is a side viewing scope, and that's why you see the proximal flange, and it's just about to come out. I'm pushing it out now, all very controlled, and there it popped out. Now, of course, I fell back into the antrum, so I'm now going to just advance forward like this. Wow, there's pus coming out. And we can just pull out the, pull it out slowly that you can so that I can just show the tip, Tom. I'll get it a little bit more there. Oh, wait 1 second. Let me just get it into better position. Look at that pus flowing out. Obviously, the drainage was not very good, the percutaneous drainage. So let me just get into a better position here. And I'm trying to suction. Oh, Tom, if you can just show the tip, the ceramic. Let me see if I can just show that. It's just a little bit hard to see. I want you just to see that. Do you see that tip there? See the wire running along the side? That's that diathermic wire that gave me that cautery that enabled me to very smoothly, even though this is 10.5 French, I could very smoothly advance the catheter into the gallbladder. You can do the same, of course, with a pseudocyst. Yeah, got it. Or the bile duct. Now I'm going to advance back in. And because we have a lumen-opposing stent, I don't need to be afraid that the stent's going to dislodge. There's just a lot of pus coming out here. So the next step that I'm going to do now is once I get a good view of the distal flange, I'm going to dilate the lumen of the flange, and there we go. I'm right up against the flange now, just trying to give some air. It's flowing very vigorously, so that's why we're having difficulty seeing. So I just have to keep sucking and aspirating for a moment.
Can I have a magnifying view of the fluoroscopy? See the position of the stent.
Ah, yes, that would be great. Can you magnify up? There you go.
Magnify more. One more.
So I think all the contrast is coming out.
Okay, good.
From the gallbladder.
So you can see the still not fully open of the center of the stent.
Yes, that does need to be dilated up. And I'm just struggling with the view here just because there's so much pus draining out of here.
So we can see this because of the lumen of this stent is much bigger than the PDBD or external drainage.
Let me switch for a gastroscope,
yeah,
okay? I'm going to switch for a gastroscope because, as you know, this is oblique viewing, so it's going to be a little bit more difficult to see. So we'll just switch over to gastroscope. We'll do our dilation with the gastroscope and then enter into the gallbladder, and then we're going to do the debridement and hopefully pull out any residual stones in the gallbladder.
Is this a minimum or maximum diameter between the gallbladder and the duodenal wall for you to do this drainage? Is that maximum?
Yes, 1 centimeter.
1 centimeter,
1
just
centimeter,
like pseudocyst.
yes, is very generous. Remember when Anthony measured out the distance before, it was about 4 millimeters, right?
Yep.
So, but on EUS, it looked like a big gap between the duodenal wall and the gallbladder wall, and you could see that echogenic tissue. That's fatty tissue that is in between the two. So those two walls are not fused together. And I think what we underestimate is the degree of fusion between extraintestinal structures and the bowel. And the only time you have fusion is actually for pseudocysts, and only for chronic pseudocysts. So when you have Remember, a pseudocyst is defined by being present for at least 6 weeks. Otherwise, it's called an acute fluid collection. So if it's a pseudocyst, it's been there 6 weeks, and 6 weeks is enough to create fusion with the stomach wall, for example, or the duodenal wall. Walled-off necroses are also defined as being present for at least 6 weeks. So there, again, you usually have good fusion. That is why you can see some of the endoscopists perform very aggressive tract dilation, sometimes to 20 millimeters with a 20 millimeter balloon, and they don't perforate. And the reason why they don't perforate is because there is good fusion. But if there is not good fusion, then of course you're going to easily have a perforation and leakage. And I have not, in my experience, I have personally inserted stents, not into the pseudocyst, but into the space between the pseudocyst and the gastric wall when there wasn't adequate fusion between the two structures. Yeah. All right, now we're ready with our gastroscope.
Okay.
And we'll insert and take a look.
So this is a jet scope, so you can do irrigation as well.
There you go. So that's fantastic that there's the jet irrigation. That means there's an accessory water jet channel. And that's always very helpful. All of our diagnostic scopes now have that. So now we should be seeing the stent in just a moment. There's the bulb, and now I'm going to go down, and there is the stent. Okay, you can see the lumen of the stent in just a moment. See the lumen of the stent there?
Yeah.
Okay, we can
Very
actually kind of peer into the gallbladder. You can see still some purulence draining. So let's get our balloon. And the balloon we should use is a 12 to 15 CRE balloon.
Can you go down to D2 now?
All right, so I'm advancing this through the working channel. And what's also nice is because of the flange here, it actually stabilizes the position of my scope. If you had a tubular stent, and of course it doesn't stabilize my position in the bulb, that can fall out, but in terms of the position of the stent, it helps stabilize. So
Ken, I saw that stent is very close to the pylorus.
Yes.
It seems that it's covered the passage to the second part of the duodenum.
No, I mean, I realize that right now it may lend that impression, but afterwards the stent, especially after we dilate, it's going to
shorten.
It's going to shorten, and it will align itself very nicely and hug the wall of the duodenal bulb. See, now I can advance under direct endoscopic guidance directly into the gallbladder now. Okay, just going to make sure that I have enough of the balloon inside. I'm going to pull back, and of course, I want the balloon to straddle, so now we can start to inflate. And what can happen is this typically happens, is it pulls me into the gallbladder. I don't want that. So deflate a little bit, let me pull back. And of course what I'm trying to do, this is a common problem also when we used to perform tract dilations for pseudocyst drainage. We don't do that anymore. We never have to dilate the tract. But before, the balloon would either slip out or it would slip in. So I need to start again, go ahead and start going up again. I'm going to try to pull back as he's dilating so that I don't slip back, I don't get sucked in again. Okay, there we go, that's better. So I've been able to stabilize, and I can even advance a little bit and see if I can push myself up against the balloon and look through the balloon, and you do that by just giving some water. There, the balloon's all the way up. Beautiful. So it's dilated, go back down. Oh, you can go ahead and go up then, continue. All right? So you can do all of this under endoscopic guidance very nicely. Okay. So now we're at 15, go down. Now, back in the day when we used to do tract dilation with the balloon and then do necrosectomy, what we would do is as we deflated, we would pull the balloon into the working channel of the endoscope, and that would help us get in. There's no need for that now because we have a port. So all I'm going to do now is just very gently, because I don't want to risk that if maybe the end of the balloon has caught the stent, that I pull the stent out. It is lumen opposing, it is anchoring, but we still want to be careful. All right, so now I'm going to advance forward, and let's take a look. This is where we want to give a little bit of... now remember, this is a very inflamed gallbladder. Let's get the water pedal, please, for a second. Yeah. So here we're looking in, and you see the stent in the catheter, the percutaneous catheter inside there. This is where having this water jet is very useful. And I'm just going to wait here just for a second, just so that I see where I'm going into. And then also on the diameter of the scope is a little large here, so I just want to be careful that I don't accidentally push the stent in. It's a little snug. But there's the inside of the gallbladder, right? You can see some of the debris.
You can actually compare the external drainage tube with this stent. Okay. That's why the external drainage could not perform very well in this case.
Yes, correct. Now this is just like necrosectomy in walled-off necroses. Now what I like to do is be very careful with the gas insufflation, very careful, and I prefer to use more water. And in the walled-off necroses, I like to use H2O2 to also assist with the debridement. What I'm looking for here is if there's anything I would need at this stage right now to remove. I'm inclined to be conservative right now. If we have hydrogen peroxide, I would flush some of that inside of here, but otherwise I do what I call vigorous irrigation. Vigorous irrigation like this. You just want to get everything nice and clean and wash out all the purulence, wash out any loose debris. I think when you have such an acutely inflamed, I just slipped out, acutely inflamed gallbladder, you don't want to manipulate too much in the first session. Be conservative. You can come back in a week, and then you can more aggressively debride. But you have a beautiful port that you can use in a week and go right inside like this. So this is the concept of a stent as a port for transluminal endoscopy. So this is entry into the gallbladder, no different than entry into the duodenum or the colon. It's an extension of the gastrointestinal tract. So there's some purulence, and I'll debride this out a little bit. And so we'll just wash this out over a few minutes. So I infuse water until it fills up like this. And then when it's nice and full, I'll aspirate again. And I'll just do that and maybe use about 500 to a liter of fluid to debride out the gallbladder. But I'm not going to mechanically do much today because the wall is friable. You can see it's already starting to ooze there, right? Just from some contact. So this is a chronically inflamed, friable organ right now. So you want to be very careful, especially with how much air you're putting inside of here. You could easily, I think, perforate if you're not careful about that. And that's why I think it's better to use water. Well, that's basically the procedure. I don't think there's anything further we need to do. One of the studies that we're starting is investigating the advantage of placing in this type of an infected cavity, whether placing a nasal cystic catheter has benefit over just drainage alone. That remains to be seen because we have such a large opening of 15 millimeters. Perhaps that's sufficient. And if you just go in weekly, and it may require no more than 2 or 3 sessions, and debride out the cavity, again, it's a 5-minute procedure because you can go through the stent as a port, so you have easy access. You don't have to redilate. You don't have to remove a stent and replace the stent. That strategy may be better than placing a nasocystic catheter because, to be honest, the patients hate it. They hate nasocystic catheters. They often pull them out, and you can actually discharge the patient home once they're clinically stable. whereas, of course, with the nasal cystic catheter, you would need to keep them in the hospital. I'm going to stop here because you can see how friable it is, and I'm just going to pull back, and I'm going to give you one last view of the stent right here.
Okay.
Okay?
Thank you very much. Very nice demonstrations. One question for Ken. One question.
Yes.
For this old gentleman, we may not take out the stent, but how about for younger people?
Yes. So
can we take out the stent after, say, a few weeks? After?
Yes, you could. A mature tract will have formed after 1 month. However, our experience from animal studies has been that you need to leave the stent in for 3 months to have a tract that remains open, that is durable. So if you want to have a tract that's not going to close down, you need to leave the stent in for a longer period of time.
Thank you very much. Thank you. Can I go back to room 3?